For those of you who haven't met me, I'm Paul Hein. I'm your PGY4. My talk today is going to be on why healthcare is so expensive and what can we do about it. This is obviously a very complicated topic with a lot of different takes, a lot of different ways to parse the data, but I still think there are a couple of things to learn fundamentally as a starting point before you get to the solutions even. So just starting with a case example, this is based on a true story of a patient who I encountered while I was rotating at UCSF. We're starting out with a 23-year-old male, no significant past medical history. He's a pedestrian struck. He, per EMS, has severe left lower extremity pain, and he had inability to ambulate on scene. In the trauma bay, his ABCs are intact. He's neurologically intact. He's not intoxicated. He has a gross deformity to his left lower extremity with a thready pulse compared to the other side. He's got tingling on the bottom of his foot. You snap a portable x-ray, you see this, and it's not the hardest diagnosis in the world. And you've got a couple of items here that might be pressuring you to act a little bit sooner rather than later. Potential neurodeficit, potential decreased vascular presence. He's got the possibility of having an expanding hematoma, making it all worse. As we're going to get the reduction done, to give numbing medications and to take care of him, he throws his hands up and he says, "Stop, everyone stop what you're doing. I don't know if I can afford this. I don't have insurance." This was at a public hospital. Thankfully, we were able to talk him through it, but this started to get me thinking about the kinds of problems that our patients are going to face once they leave us, once they start getting envelopes in the mail with huge numbers on them and maybe not understanding what all those numbers mean or where they come from or how to deal with that. So talking about the US to start, we're going to first talk about the big picture of healthcare spending and the costs involved. We're going to talk about some of the possible solutions. We're going to be a lot more focused in that regard with things that might be a lot more applicable to our day-to-day lives. And just keep in mind, this is going to be a lot of pre-COVID-19 data. Some of it even predates Obamacare. Obamacare didn't change things enough to change the relevance of the data, in my opinion, but some of the numbers might slide slightly towards one way or the other. But this is an imperfect science, no matter how well you do it. So just talking about US healthcare spending as percentage of GDP, it's been increasing compared to other countries since the 1980s. A lot of the information about this comes from the Commonwealth Research Group, who compares 11 wealthy countries. You can see the US is clearly taking off compared to others. This graph goes until 2019, at which it was about 16.8% of the US GDP was spent on healthcare. The next highest one is Germany at 11.7%. It makes a lot of sense that we would have some pretty high private expenditures. We all know that our system is a very private one, but surprisingly, the amount of public expenditure and mandatory expenditure is also quite high. And if you look at the diamond on this graph, which you can get a closer view of here, this diamond, about midway through, is the amount of government expenditure on health. Meanwhile, the X is private. So some companies actually do outrank us in private. But our total is far above any other country. Per capita, we're spending about $11,000 per person per year, compared to the next most expensive country at Switzerland is about $7,000 per year. Here we are at the top. So surely we get proportionate outcomes, better healthcare outcomes, higher quality, lower, more value per dollar. The answer is absolutely not. Here's a top 10, and here's the United States coming in around 37. There's a lot of different ways you can slice the data. We're typically in about the 30s. The only time in which we come anywhere close to the top 10 is when, on a lot of those Commonwealth studies I mentioned, where we come in at about 11th place. That's because it's out of 11 different countries. So it's one way to falsely elevate your numbers. A nice way of summarizing everything we're talking about here is you just take these two things, put them on an axis. Our healthcare spending is the highest, our quality is low, and overall performance is the lowest. So what does this mean for your individual patients? As far as individual patients, this is a study out of Washington State in 2013 with 170,000 patients, showing that as, I apologize, this is a study of the US. This study just shows that consistently up until 2016, which is about the most recent data I could find, medical bankruptcy continues to be the #1 cause of bankruptcy in the United States. There's some overlaps. If you look at the percentages of it, they don't all add up to 100. They often add up to over because there can be more than one cause. But medical bankruptcy is consistently a winner. If you're thinking about the numbers on a deductible for how much a person might have to pay per year, just the magic number for me is $1,000, where only 40% of Americans can actually tolerate a surprise expense of $1,000. This is a study done in Washington State in 2013. This is the one with 170,000 patients. In this study, they found out that if you take a patient with cancer and you match them to age, cohort, income as much as possible, ultimately, cancer increases the risk of bankruptcy by 2.5 times. The logical extension of that study is this next one, which looked at overall trends in cancer rates, bankruptcy, and mortality, finding ultimately that filing for bankruptcy while you have cancer significantly increases your chance of dying. So where does this extra cost come from? There's cost that you expect to pay, which is the cost that everyone else is paying. So if you're paying more, meaning in this case about 5.1% more, this delta right here, what is contributing to that? It's worth noting that 5.1% of your GDP, if you're talking about, this is from this 2019 data, if you're talking about $21 trillion, you're coming in around $1.1 trillion, which is a lot of money. So this money isn't going nowhere, but where are we paying it into? If you ask 5 people about what's causing healthcare to be so expensive in the United States, you're going to get 10 different answers. One cause that a lot of people bring up is, do patients overutilize? Do patients treat the healthcare system like a commodity? Do they treat it like a product, like an iPhone? And do they just consume without thought to expense? The answer is probably not. Turns out that Americans go to the hospital less than other folks. And when we do, they're often for shorter stays. Now, granted, they are often more expensive per day of hospital, but so the actual price can be a wash, but as far as the actual utilization is actually less. That also pans out to clinic visits as well. The average American goes to clinic visits approximately 4 times per year. There's actually one study that in which they were saying that people from Japan were going about 12, but ultimately it is higher on average in European countries. We also do a lot of surgeries outpatient that are done inpatient in other countries, hernia repairs and gallbladders being 2 of the biggest ones. Do we have more comorbid patients? Do we love our fast food and our alcohol and cigarettes? Turns out that's not exactly the case. We are about as sick as other countries. We have a lot more obesity. We're still #1 in that, but we have less tobacco, less alcohol. So it may come out to be a wash. There was one McKinsey study in 2010 showing maybe it was causing an increased cost of $25 billion. Still worth thinking about. Still, if you can prevent any of these things from happening, it's not just a comparison contest. Any savings you can get are of value. Is it malpractice in defensive medicine? Are we doing a lot of over-testing for fear of lawsuits? The answer is yes. We do more MRIs and CTs than other countries. That also extends to a lot of other diagnostic testing, especially in the outpatient setting. Our biggest estimates are, this is somewhere around $55 billion per year. You can try to pass tort reform laws. This is pursued in Texas. It dropped prices by only about 0.1%, which brings up a couple of other aspects of why that price isn't going down, which is one that everyone trains to get a trope on every single patient to avoid malpractice. Even if you get rid of the malpractice lawsuits, you still might not change the culture of medicine. And so for 30 years, those physicians will train other physicians to continue the same pattern. Additionally, when people are doing this increased utilization, like more CTs, more MRIs, it's possible that it's not just out of a CYA perspective. It might actually be because of things like fee for service being the model of how the US healthcare system works. It is always possible that someone benefits from it. Another aspect about the whole malpractice thing is that it may influence a patient's decision to pursue a malpractice lawsuit if in addition to losing their hand in a tragic medical mistake, that bill from that hospital visit is also bankrupting them. This I haven't really seen very well explored, but is been brought up conceptually, at least by more than a few folks. Are doctors and nurses making more money? We obviously make more money than other countries just because we have a GDP, but when you correct for GDP, do we make more even then? The answer is yes. We make potentially enough to cause an increased cost of the US healthcare system of $75 billion per year. I can't help but mention, just given that a fair number of people in the room probably have a negative net worth, that given that we have an increased cost of schooling that we have to pay upfront and then make up for it later, that might affect how we perceive how our job should reward us, instead of us going to a country where the education is either significantly cheaper or potentially even free. Is the high administrative costs of insurance companies contributing to this? The answer is yes, probably to the tune of $90 billion. That is variable that you can control depending on what kind of insurance company you're talking about. The administrative costs of private insurances are usually coming in around 10 to 15% based off of the estimates, or $700 per person. They're significantly higher than Medicare, which surprisingly only has an admin overhead of 1.1%, even though we typically think of private companies that potentially being leaner, potentially being more efficient. It doesn't seem that that's the case. This is a really complicated metric, and that you could almost go into a lecture in and of itself on this topic. But just to talk about how complicated this is, that private insurance to Medicare comparison does include the fact that Medicare uses about 10 different government agencies, most notably Social Security, IRS, and FBI, to manage parts of it. So that is included in the budget, but it doesn't include the part where Medicare has a significant part of it managed by private companies, which themselves have insurance admin costs. So those all of the admin for Medicare Part C, which is where insurance companies get a bolus of money and do whatever they want to with it. And if they can create savings, they pocket the surplus. And Part D, which is just all outpatient drugs. If you take those admin costs, which when run by a private company are more expensive from an admin perspective, that still leaves your Medicare, including private involvement, at only 7%, which is still significantly better. So when people talk about Medicare expansion, the question is are you talking about a pure Medicare thing with a really optimized economy of scale where you might still continue to pay low admin costs, or are you involving private insurances, which may make it more expensive? So a lot of people can argue back and forth about how it's going to actually pan out in reality, but these are the numbers as they've been researched. So how about drug prices? We do pay significantly more per pill on an outpatient basis than most other countries. We don't have price controls, and we have reduced negotiating leverage because we're not negotiating as a giant insurance pool. So here we're probably paying about $100 billion more than we should be relative to our GDP. Drug prices are not negotiated by Medicare. They're negotiated by insurance companies privately. So Medicare is actually not, there's legislation saying that Medicare is not allowed to negotiate for drug prices by themselves. They include a lot of small insurance companies, which shrinks the size of the pools and therefore gets you worse negotiating rates. It's actually been talked about by a couple of folks. It was actually talked about, at least out loud, by Donald Trump, and it's being apparently considered by the Biden administration to actually allow the Medicare to directly negotiate for drug prices. There's a lot of people who are opposing this, making drug lobbyists the third largest folks of lobbying in Congress. And this isn't a hand-waving thing. There's a pretty direct relationship between the lobbying and them deliberately and out loud making a point that this will be bad for patients somehow. How about everything else? There's a lot of money missing, and there's the fact that we are paying a whole lot more of money, about $470 billion for just the inpatient outpatient care. This makes it hard. This is the stuff we care about and like. Inpatient's actually significantly cheaper than outpatient, which is a pretty consistent trend comparing different countries. Why is this happening? It's a little bit up for debate as to where the problem lies. Are we paying more for devices? Are we incentivizing utilization with fee for service? Part of this, which was separated out in the analysis, was the extra pay for doctors and nurses. This is hard to account for, but there is one thing that is hard to calculate the exact numerical benefit of, but that is undoubtedly influencing this in a huge way for us compared to other countries. And that is how negotiating works. When you negotiate as an individual, you're at one extreme of the end. You have something called inelastic demand, where effectively the person giving you medical services has effectively all of the power in the relationship. If you have, if there's a life-saving pill that's going to cost you $7 a month, you will pay for that pill to save your life for $7 a month. If that pill instead costs $200 per month, you're probably going to find a way to pay for that, because you can't choose medical care. It's not a free market. It's not an iPhone. You don't have the ability to say no. And so what this looks, if you look at the curve right here, it's a little odd because the dependent variables are backwards, but if you change the price here, you can change the price as much as you want. Your demand is barely going to change, because people are going to fall off the demand curve are people who are going to lose access to a life-saving medication, which might not even be by their choice. Meanwhile, if you have larger pools, you get better deals, which is why the largest insurance pool in the United States, which is Medicare, gets better deals than just about any commercial insurer. This does vary by service. You can see it's pretty close together for the office visit. Meanwhile, other surgeries, and you typically, like, the further specialized they go, the less Medicare is going to reimburse compared to commercial insurers. The way doctors make up for this is that Medicare patients often are sicker. Remember that these are all patients, they're generally patients who are over 65 years old. So these patients are more likely to have other things that are going to ultimately be billed for. They're ultimately going to be more money-making patients. Leading to the excellent quote, Medicare doesn't negotiate rates, it just sets them, and everyone else has to deal with it. You can try to engage with Medicare through the government, through lobbying, et cetera, but their swing is pretty powerful. So there's a lot of different things we've talked about here. There's a lot of different causes. And if you ask anyone what the reason why healthcare is so expensive, they might just say one answer. I think the lesson here is, don't just think of one thing. There are many things, and they are all important. Here, the extra cost being the multiple colored slices, the green being what we would expect to pay. So what are we going to do about it? We can, as individuals, as doctors, as folks who work in an emergency room, we can have cost reduction by quality improvement. We can try restructuring fee models. And there's a couple of other approaches which might be able to get us some gains, maybe. What can we do with our input into the emergency room to save money? We can reduce the uninsured patient population. There's a pretty famous paper that came out in 2019 about the effects of the Affordable Care Act, finding that by 2016, it hadn't actually reduced the number of emergency visit presentations by people who signed up for the ACA. In fact, they had actually slightly increased. However, it significantly reduced the number of uninsured visits. Those uninsured visits now being cheaper, because since a person has any kind of insurance, even if they're underinsured, they often have access to the negotiating pool of the insurance company, lowering costs for them. Care coordination seems to be a consistent winner in the literature. A lot of the other cost-saving measures people have tried have middling results, or they work in some times, but not all the times. Care coordination seems to work really well. This is fighting things like bounce backs, fighting things like unnecessary presentations when the person can just be managed at home with a close outpatient clinic follow-up. England has been doing a lot of work with in-house visits, which actually come with an ambulance. They have phone triages, which are now also becoming especially with COVID in the United States, there are a lot of hotlines for this sort of thing. And certain workplaces, if it's big enough, you can just have an on-site provider. The ultimate theme here being, if you're keeping people out of the emergency room, you do save money. What can you do for throughput? So once a person's already in your emergency room, how can you make things work a little bit there? You can improve staffing, and you can add a physician in triage. The physician in triage in particular might actually help time to discharge, but might actually not. There's plenty of studies that would show that it just reduces the time for the patient to be seen, but doesn't really improve flow. And none of it really seems to help admissions, because even if you have more staff, the person who's getting admitted is likely going to be there for an amount of time that you're not going to make a meaningful difference on. Care coordination teams, again, they can fight bounce backs, when they see the patient in the emergency department, and they can try to do what they can to avoid social admits. for people who are, for example, nursing home patients or things like that, and then, find you a dispo faster by, for example, having them in obs for 36 hours instead of being admitted for 2 weeks. Mid-level providers, there is mixed evidence. I know there's a lot of strong opinions on this, but they are part of the conversation. I saw folks go both ways on this. I admit this is a place that I could learn a little bit more about too. Now I'm just talking about payment models. This is something we've all heard a lot about. It's kind of like the brachial plexus. I always have to look it up and remind myself again. But just to start, fee for service is what we do. If we do a thing, you get paid for it. If you order a test, if you order a scan, if you admit a patient, that you will get paid for. And it's kind of nice to know that you're going to get paid for something, assuming that we're all trying to do the right thing. No one knows the outcome of any situation. But if you don't have good virtues, there's a concern that people have, which it often goes by the nickname of dark incentives, which is that people might be doing things not purely out of the goodness of their own heart, or if there's something that they view as neutral because it's just going to the insurance company, right? Some providers do things like multiple billing Medicare. This is basically just finding a medical rationale to do something that ultimately is not the same thing, even if it might blur the line between honest practice and actual fraud. Value-based care is becoming the new hot trend in how people think about this. For some history, in 2010, the ACA outlined the creation of something called the CMMI, which is Center for Medicaid and Medicare Innovation. They do a lot of stuff talking about this. There are many, many, many different ways you can do value-based care. The ultimate important part is that it's based on your outcomes. So it's based off of, was this the right thing to do for the patient? And part of it can have a retrospectoscope approach, and part of it can ignore the actual individual circumstances, and it's by using population data instead to say, are we going to pay for this based off of the fact that it might not actually have a positive outcome in the end? But there is a meta-analysis posted about this in the New England Journal pretty recently, showing that there are some successes in small groups of physicians who involve care management and have a patient population that they own, but that no one has really successfully converted this to succeed at scale on the state or federal level. In the emergency setting, in an emergency department alone, this isn't really something that we can fully wrap our hands around. Some people are trying to come up with approaches. ACEP has one that they've called the AUCM, for the acronym of AWESOME, that is currently being looked at effectively by healthcare bureaucrats, and it's apparently gotten a little bit stuck in the weeds. But that could be used as a value-based care model to actually end with us getting reimbursed for it. The one thing to note about value-based care is that this might result in a patient coming into your emergency room, you ordering tests, and based off of your clinical suspicion and sincere concern for them, but the value-based care group might not actually reimburse you for it because they said, oh, well, that was just GERD, it wasn't actually ACS, so why did you order a trip? Capitation is an interesting model. Maryland's actually been doing this since the start of 2014. What happens here is that based off of your number of patients, the state of Maryland or whoever's funding the bill will give you a set amount of money, and that is all you get. So your job is to reduce the amount of cost of that patient as much as you can. So some people joked in Maryland that this got hospitals interested in public health overnight, because if you can prevent people from being high utilizers, had problems off at the pass, you can save a lot of money and therefore make money. This is pretty early stages, so it's I don't personally have any strong conclusions about it, but it's kind of like you're passing the public health mindset on from yourself as, let's just say, a government agency on down to like a smaller hospital group, and whether it's feasible for them to be doing that is an interesting debate. So a couple of other things you can do. These are just other little approaches that are here and there. One of them is something called permanent supportive housing. You might have also heard of it by the popular name of Housing First. This is pretty famous in Colorado and is pretty successful at getting us some savings. So effectively, if you have these super high utilizers, and this being a model of high utilizers, in this case was for people who are undomiciled often have things like substance abuse or psychiatric diagnoses or dual disease, meaning both, and probably their own share of healthcare conditions too. I'm using this as an example to compare to, for example, very old geriatric patients who themselves may be a different kind of high utilizer. If you create a dedicated program, at least for high utilizers in Denver for folks who are undomiciled and frequent flyers in EDs, if you pay about $13,000 in housing, the amount of savings you'll get, which isn't just in healthcare, but is in a couple of other areas of society too, you'll actually save money per patient. There's a huge amount of variety here based off of your patient selection, based off of your approach. I was able to find out for one program that specifically did this, and note this is a lot different than just a regular old shelter program. And it's pretty high investment, involves social workers and people keeping patients in. New York City, unfortunately, in the study I saw, it actually resulted in spending an extra $388 per person. Now, from a humanist perspective, this might be worth it if you just want to improve the quality of life of people, because if you're able to prevent people from being in an emergency room in a criminal justice system or in a shelter system, if there's a better house available, that could be worth $388. And it's also not impossible to optimize this. Hotspotting frequent flyers is another area of interest for a lot of different folks, but there doesn't appear to be anything systematic on a nationwide level, other than the care management, as I had previously talked about. Cost transparency is coming up as a topic. We have ever since October 29th, people, the government, CMS, who runs Medicaid, mandated that if you're going to participate in Medicare, or I apologize, who runs Medicaid and Medicare, if you're going to participate in Medicare, you have to be transparent about your prices. So in the next couple of years, we're actually going to start having mandates saying that we need to post our prices online. Some hospitals are already doing this, but some hospitals are already doing this and posting it deep in their website, or posting it in a format that's difficult for an average person to read. This seems pretty readable right here with the cost of these various MRIs. There's plenty of cases where it might not be legible. Think about if it was listed by ICD-10 code. So the actual effect this will have might be a little bit of a wash. It might meaningfully inform consumers. It might also not. And it might provide some competition between hospitals, but they might argue that they have that je ne sais quoi that is the value that you get for the extra cost per hospital, to say the extra cost for MRIs, that's paying for a safer healthcare experience. So there's a lot of wiggle room for how you could be branded. Just talking about larger reform, I am intentionally not talking about this today. It deserves its own lecture. It is, I came into this lecture and doing all this research pretty optimistic, but I found out that it was, of course, a lot more complicated than I'd thought, even when I already thought I had researched it. There's a lot of different ways to implement it, but keep in mind that if you were going to use this to create a collective bargaining pool to drive prices down, that's going to create a huge shift in the healthcare economy. Kind of like how if you were to solve the healthcare crisis overnight, that's 5% of the US economy that is going to have to be restructured. And since that's not all going to get reallocated immediately, that's called a recession. But this is something that people have obviously talked lots about. Every single person in this room has heard about it. Even if you're against it, you should look into it, because it's possible you're going to get it whether you like it or not. But this is, could be a future lecture for anyone who wants to talk about it. Lot to talk about here, but the large benefit here is ultimately larger negotiating pool drives down prices. Good for the patient, not good for everyone else who has benefited from being on the upper hand of the negotiating table. Some closing thoughts. There are no easy answers here. This is a multifactorial problem. It's nice to be able to point at one single thing, but simple answers, unfortunately, in this case, are not going to be right. Cost is a patient-centered outcome. I really, really, really want to focus on this. When people say that, oh, don't get the CAT scan, don't get the extra labs because it's intellectually lazy, that is true. That'll never not be true. But I think the thing that matters more is if getting your electrolytes slightly faster on the blood gas costs $250 to the patient, maybe if they're not in critical renal failure or not acidotic, maybe you can just get the basic metabolic panel and take it from there. The most important part of this lecture for me that I can impart to you would be the part where cancer increases the chance of bankruptcy. Getting bankrupt when you have cancer increases your chance of death. So if you can reduce costs, that helps your patient. It's not just for someone who's trying to prove a point. As far as physician leadership, I think this should also be really, really focused on. I think we should be trying to grab the reins here. Some people might argue that the part of the problem of why healthcare costs have been expanding is that physicians are no longer the dominant players in the field. I think that given that we are trained from the start to take care of our patients, I think that system run by physicians might intrinsically have some advantages over one that's run by folks who aren't and might not have the patient's best interests in mind. Finally, all of the problems we talked about are very big problems, but a lot of the solutions I talked about are small ones. And those are things that you might actually be able to meaningfully do. Yes, there are big problems that require big solutions, but I think in this day and age, instead of waiting for everything to magically fix itself and waiting for the government to get a crystal clear mind and find an answer to an incredibly complicated problem, and then waiting for them to do that in a way that somehow doesn't screw up the economy, it means that you are basically waiting for a black swan event, and you should just try to act in the meantime for the benefit of your patient, because they are the people who matter the most. Huge thank you. This was a really big and complicated topic. Huge thanks to the admin and policy team, Dr. Khan, Dr. Buckridge, and Dr. Mehta and Dr. Brewster. Also reach out to a lot of our old seniors, Angela Kai, Adrian, Noah, and also just ran it by Matt Behrens. Thank you to everyone for helping out this. Goodbye references. Thanks so much.